everyone. My name is Liz Lazo, and I would like to welcome you all to today's national webinar hosted by the AIDS Education Training Center National Coordinating Resource Center, the AETC NCRC, presented by the MidAtlantic and Pacific AETC. Today's session is part of the HIV and COVID-19 Winter Webinar Series. Today's speakers are Drs. Monica Hahn, Gregory Phillips, Lauren Lee, and Dylan Feld. Dr. Monica Hahn is an associate clinical professor at the University of California, San Francisco, UCSF, in the Departments of Family and Community Medicine and OBGYN. She serves as clinical director and co-principal investigator of the Pacific AETC. Her clinical experience includes co-directing the Family HIV Clinic, a family-oriented HIV primary care clinic at San Francisco General Hospital, and providing perinatal HIV care to people with and or affected by HIV as Associate Medical Director at HIVE Clinic, also based at San Francisco General Hospital. Monica co-directs an HIV specialty concentration training program for the UCSF Family and Community Medicine Residency Program. In her role as a medical educator, her work centers on advancing anti-oppression and critical race theory frameworks in medical education and training programs. She is an alumnus of the UCSF programs in medical education, PRIME, Urban Underserved Program, and currently serves as its Director of Inquiry and Evaluation, where she engages in training and mentorship of medical students. Dr. Gregory Phillips is an assistant professor at Northwestern University and director of the EDIT program within the Institute for Sexual and Gender Minority Health and Wellbeing. He is an infectious diseases epidemiologist whose research focuses on understanding factors that drive health inequities among minoritized populations, particularly sexual and gender minority populations. He is currently the principal investigator of multiple NIH-funded awards focused on HIV and COVID-19 disparities. He is also the PI on multiple projects funded by the Chicago Department of Health to oversee the evaluation and quality management of Chicago's HIV portfolio. Dr. Phillips also holds leadership positions within the American Evaluation Association and the Center for Culturally Responsive Evaluation and Assessment, and is co-director of the Ending the HIV Epidemic Scientific Working Group within the Third Coast Center for AIDS Research. Dr. Lauren Beach is a research assistant professor within the Department of Medical Social Sciences in the Feinberg School of Medicine at Northwestern University. She is also associate director of the EDIT program with Northwestern Institute for Sexual and Gender Minority Health and Wellbeing. She holds a PhD in genetics and a law degree from the University of Minnesota. Dr. Beach investigates the epidemiology of chronic physical health conditions over the life course among diverse SGM populations and people with HIV. She also studies how multi-level health and identity-related stigmas affect healthcare quality, chronic condition management, and health outcomes of marginalized populations. She holds a K-12 Career Development Award from the Third Coast Center for AIDS Research to investigate social and biological mechanisms contributing to heart failure with preserved ejection fraction among people with HIV. In July 2020, they were awarded an R01 from the National Heart, Lung, and Blood Institute to add measures of sex, sexual orientation, and gender identity to the Year 35 exam of the Cardia cohort. Dr. Beach is also a proud, long-time bisexual community advocate. And Dylan Feld is a research project coordinator with the EDIT program at Northwestern University, where she helps to lead research development and dissemination efforts. As a trans feminine public health scholar, her work prioritizes uplifting transgender community leadership and ownership of health equity efforts. Since 2017, she has worked with Drs. Phillips and Beach across a variety of projects related to sexual and gender minority health, including the evaluation and quality management of Chicago's HIV portfolio, as well as designing and evaluating new survey tools for use among gender minority populations and developing and delivering trainings on sex, sexual orientation, and gender identity, including demographic data collection and analysis. Since March 2020, she has been helping to shape and expand EDIT's research portfolio in response to COVID-19 with an emphasis on advancing work responsive to the experiences and needs of sexual and gender minority populations. Okay, today's speakers have no disclosures. And our learning objectives, our speakers today will explain intersectional structural discrimination and its relevance and context in the landscape of HIV and COVID-19 as it pertains to the health and well-being of marginalized populations, particularly LGBTQ+ and racial ethnic minority populations, analyze the history and present state of the HIV pandemic and the lessons available to inform our response to COVID-19, identify the specific factors which place marginalized populations at greater risk for COVID-19 and HIV, describe empirical evidence of disparities in HIV and COVID-19 among marginalized populations, and identify how the two conditions are related. Discuss strategies offered by social justice, anti-racism, and LGBTQ+ liberation frameworks, and history to mitigate the impact of disparities, and share resources to support ongoing provider learning to promote health equity. So it's my pleasure to now hand it over to Dylan.
Awesome. Thank you so much, Liz. Good morning, good afternoon, and welcome, everybody. We're incredibly grateful and excited to have you all here. We wanted to open our presentation today with a land acknowledgement, and we wanted to specifically share that those of us on our team who are coming to you from San Francisco, California, are coming from Ramaytush and Ohlone land. And those of us coming to you from Chicago, Illinois, are coming from land originally stewarded by the Council of the Three Fires, the Ojibwe, the Potawatomi, and the Odawa, as well as the Menominee, Miami, and Ho-Chunk nations. Chicago is and also continues to be a site of trade, community, and healing for many Native American populations. And we give this land acknowledgement for a couple of reasons. First, because colonization is an ongoing process, and therefore decolonization must be as well. Recognizing the history and the ongoing contributions of the original stewards of these lands is a way to resist the ongoing genocide and cultural erasure perpetuated by colonialism. This is also incredibly important to what we're going to be talking about today specifically, because the history of colonization is inextricable from the inequities and COVID-19 impacts which we see in Native American and tribal communities currently. So we encourage you to take the time, if you haven't already, to learn about the history of the land that you are living and working on as well. And with that, I'm going to turn it over to Gregory to get us started.
Thank you, Dylan. I'm going to be giving a quick overview of how HIV has emerged and how this has really set the landscape for what we know and what we're talking about with COVID-19, especially because we all know that there are a lot of parallels between these two pandemics. So I'm guessing I don't have to go into too much detail for people on this call. I assume you already know a lot about the history of HIV. But these two MMWRs that came out about 30 years ago really highlight where the HIV epidemic started. These two early reports, now we know that there are a lot of MMWRs that are highlighting the different things that are coming out about COVID-19. And it's really important to recognize how this started, how people are being referred to as being infected with Kaposi sarcoma or pneumocystis pneumonia. The original version of AIDS was called GRID, or gay-related immune deficiency. There was a lot of stigma around people who had HIV or AIDS. A lot of populations were disproportionately impacted. And a lot of this was driven by poor response to AIDS and HIV. Ronald Reagan, who was president at the time when these MMWRs came out and when AIDS first emerged, was very slow to respond to AIDS. There was very little in his presidency, in his policies, that actually did anything to protect against HIV or protect the populations most impacted by HIV. And because there was little incentive for the administration to act, because the populations they cared about weren't being impacted, they didn't really have any political motivation to go after the support and the resources and the political goodwill to actually address the epidemic. Still sticking along the lines of stigmatization and the way the HIV epidemic started out. Patient zero, we all hear about so much, especially as epidemiologists. This really started for the AIDS epidemic back with William Darrow at CDC, who was tasked with tracking the origins of AIDS in the United States. We know so much more about the viral evolution of HIV now. There's so much funding and interest that goes into phylogenetics, but this is where it all really started. And his early outbreak investigation of where HIV started identified this one person, Gaetan Dugas, who was a flight attendant. He was identified as patient zero. He was highly stigmatized. He was all over the news. And it turns out that there wasn't really a patient zero. It was really just a letter O instead of a zero. And all of this just led to extreme stigmatization around who had HIV, who was impacted, who was driving the HIV epidemic. And we see lots of parallels with this within who is impacted with COVID-19, who is not wearing a mask, who is not socially distancing. We have learned a lot from HIV, not enough, I don't think, but here we go into how a lot of work with the phylogenetics of HIV has shown that Dugas was not the index case. HIV existed well before he was infected, but our instinct to blame a single individual or group has not gone away. We still blame people who are disproportionately impacted by diseases, who are unable to control whether they're at risk or vulnerable to disease or HIV or COVID-19. We still tend to attribute all of that, and that's not gone away. And unfortunately, we see that very much within the different areas in which COVID-19 has impacted the social and economic sector. We talk a lot about how HIV is gone. There's this belief that HIV is no longer a big deal, that HIV isn't of interest, people aren't being infected anymore because there's all these conversations around getting to zero, ending the HIV epidemic. And that's all great, but we aren't quite there yet. We know that people are still becoming still vulnerable to HIV, people are still acquiring HIV, and especially in the United States, we know the HIV epidemic isn't over. It's still impacting racial and ethnic minority populations, particularly Black and Latinx individuals at a disproportionate rate. It's still very much impacting trans individuals, both trans women and trans men, and men who have sex with men. It's still impacting women who have sex with men who have sex with women, people who inject drugs. And we know it's still really a problem in the southern United States, which is also challenging because there are fewer resources down there that can actually help to address the epidemic. So with that, I'm going to turn it over to Monica, who will talk a bit about the health disparities within both HIV and COVID-19.
Thank you so much. Thanks so much for that great historical context of HIV and highlighting how HIV from the beginning, due to its nature, has been situated at this complex intersection between social justice movements and medicine. And that's a great segue to talking about COVID-19 and how a lot of similar patterns of inequity have emerged from this pandemic as well. So very similar to HIV, when COVID-19 first emerged a year ago, can you believe it was a year ago, it produced widespread fear because of this threat to society as an unknown novel virus. And you know, the initial unknowns of the spread and the risk factors were just terrifying, as well as the absence of treatment. And stigma towards individuals perceived to be carriers of the infection became rampant as well. Just as AIDS was originally known as GRID, or the gay plague, you know, top leaders unfortunately weaponized language and called this the Chinese virus and the Kung flu, fueling an additional pandemic of anti-Asian racism and xenophobia, with repercussions that are still playing out today, with a significant rise in hate crimes over the past year, for instance. And that was coupled with similar political inaction and neglect and actual undermining of evidence-based policies that really could have lessened the severity and the toll of this pandemic. And it's really reminiscent of the HIV epidemic in that this really led to the further marginalization and stigma associated with infection, and then the predictable deepening health disparities that followed. And so this brings us to COVID racial inequities. We know that communities of color are bearing the huge brunt of COVID infection and mortality rates. There are striking racial inequities which mirror the inequities we see in HIV. The death rate for COVID is over twice as high for African Americans than for white Americans overall. This Kaiser Family Foundation analysis of EPIC data showed statistically significant differences between Black, Indigenous, and people of color or BIPOC patients as opposed to their white counterparts, reflecting that we just, reflects what we've seen all across the country. And here the blue bars are the infection rate and the orange is the death rate. And it's higher in all BIPOC groups compared to white counterparts. I wanted to deviate for a second to looking at data from where I practice near San Francisco General Hospital. This is data from the San Francisco Mission District. And early on, San Francisco was lauded as doing such a great job for having had an early lockdown and flattening the curve. And from a community testing project, we have this data that was really early, and it found that nearly 95% of infections were in Latinx patients in the Mission District. And it just represented here by the brown line, you can see that as the curve was kind of flattening, well, there was just a skyrocketing numbers from March to June in that group. And, it's no surprise given what we know about the population in the Mission District. It's the home of largely Latinx communities disproportionately represented in the low-wage essential workforce who could not afford to stop working during the lockdown, who largely were unable to socially distance for structural reasons such as crowded multi-generational living spaces, for instance. And really, these communities face the brunt of COVID risk to keep our society functioning and putting food on our table during a pandemic without adequate workers' rights and leave protections that others of us who had the privilege of working from home, for instance, did have. And so what do we kind of make of this data and all these news stories? Just to talk about congregate settings for a second. We know the virus itself obviously is not racist and doesn't discriminate. However, unfortunately, we know that our structures and our policies do. And so, we've been saying COVID is not the great equalizer that many were calling it at first. In fact, we feel like it's more appropriate to call it the great amplifier or intensifier of the already existing deep inequities that were here long before COVID ever was. And so early on, many pundits were kind of simplifying and blaming the inequities on more pre-existing conditions in BIPOC patients, for instance. But, I'd argue that the toughest pre-existing condition we're dealing with today actually is structural racism and other forms of structural oppression. So when we look at where the biggest outbreaks occurred, it's really revealing about what structures and what policies are driving the disproportionate burden of infections in communities of color. It begs us to ask ask questions like what structural policies led to the mass incarceration, detention, and state-sanctioned violence against Black and brown communities to get us to a place where they're more likely to be overrepresented in high-risk congregate settings like jails, prisons, and detention camps, where there were really large COVID outbreaks. This is an article on the left from the devastating outbreak that our local San Quentin prison had this summer. And other important questions, which communities are suffering most as a result of environmentally racist policies? Remember that 30 to 40% of Navajo Nation residents don't have running water today in a pandemic when washing your hands is so vital. And at one point, this article on the right is from May. At one point, the Navajo Nation had the highest per capita rate of COVID than any other state in the nation. And this is in the setting of just generations of chronic underfunding of the Indian health system and severe lack of investment in infrastructure. So, and it's in a country literally founded upon the dispossession of land from Native people, as Dylan so eloquently said in our land acknowledgement. So that was our congregate setting. I'm going to turn it over to Dr. Beach at this point to talk more about COVID disparities.
Thank you so much, Dr. Hahn. I really appreciated the summary as well, focusing in on how structural racism and social policies have also shaped COVID-19 health outcomes in this pandemic, and how that Gregory also was talking about how similar dynamics have functioned in HIV. I think that's a great transition to talk about how these dynamics also operate across a variety of other health conditions. And so this next slide here is presenting findings that came out just last month, almost a month ago today, from the CDC and another MMWR, so it's kind of what we were starting with earlier, so and mortality and morbidity weekly report. And what the CDC found, they did an analysis of BRFIS data, and BRFIS stands for the Behavioral Risk Factor Surveillance Survey, and it's a survey of about 460,000 adults across the nation each year, and telephone survey. And it's really powerful because it lets the sample size is large enough to look across the different intersections of sexual orientation, of race, ethnicity, thinking about socioeconomic status, and the CDC's report in this case was focused on chronic physical health conditions, which have been shown to be risk factors for COVID. So with that, I'm going to go a little bit into the data. And so what the CDC had found is that when they looked on the basis of sexual orientation, comparing sexual minority individuals to heterosexual individuals, that the adjusted prevalence ratios were higher across the board significantly for sexual minority individuals. And you can see that these disparities range from 1.06 adjusted prevalence to for hypertension to 1.55 for asthma, but that across the board, asthma, cancer, heart disease, COPD, diabetes, kidney disease, weight, smoking, and stroke were all higher. And this is significant because not only are these risk factors for acquiring COVID-19, the risk factors for morbidity and mortality from COVID-19. And the fact that these are higher to begin with also just is another example again of how structural stigma, racism, homophobia, biphobia, transphobia are written onto people's bodies. And so COVID-19 truly is an amplifier because the conditions were there to start for these disparities to take hold and to see everything from the history that's been discussed to what's going on in the body to the actual COVID-19 pandemic all has its beginnings and effects throughout health as a whole in society. So next up we have a study that was published also last month from the Williams Institute, which is located at UCLA School of Law. And the Williams Institute had done a survey that was looking at the impact of the fall COVID surge in 2020 on LGBT adults, and they did this looking at the intersections of race. And so what you can see here, this first slide is a graph looking at COVID-19 testing, and you can see that among LGBT people, that 7.2% of white individuals and 14.5% of people of color who are LGBT reported a positive COVID-19 test during this surge. And so it's really notable to look at these intersections. Is something I want to point out here, is that multiple marginalization also can amplify the effects of health disparities within a variety of health conditions, including the COVID-19 pandemic. Next up, I wanted to talk about some survey findings from the EDIT team. So our team had conducted a survey early on in the pandemic, I think March through August of this past year in 2020, and looking at some social factors and economic factors that could be associated with testing for COVID. And what we have in our survey, it was focused on sexual and gender minority individuals and people with HIV. You can see that we had about just over half of our sample identified as gay, lesbian, about just over a third is bisexual, that we had about 20% transgender and about 14% non-binary participants. 5% of our participants were intersex. And let's see if I can there we go. And then you can see that the percent here who are reporting COVID symptoms, you notice the high percent of transgender respondents who reported COVID symptoms, over 50%, 40% of bisexual respondents, and 22% of gay and lesbian respondents. But then when you compare that to people reporting a COVID test, those numbers are reversed. So only 4% of transgender participants compared to 7% of bisexual and 11% of gay and lesbian individuals reported receiving a COVID test in that survey of about 1,000 individuals who answered. And we also had conducted a COVID-19 resilience survey. This was coming from that Chicago Department of Public Health portfolio work. And this paper was published, you can see the citation here. And what you can see is that the paper is focusing in on structural barriers to health and social needs that were reported in relation to COVID, and this is by race ethnicity. And so what you can see is that compared to white respondents, that Black and Latinx respondents were reporting significantly lower levels of access to a medical provider to indicate appropriateness of COVID testing. You can see that access to medical services, that there were significant differences here by race, with actually white individuals reporting, I think this must be reverse coded, but anyway, I can ask Gregory about that. But shortage of food, this is probably the most striking result from the survey, that white individuals reporting no shortage of food as opposed to almost 20%, 17.3% of Black individuals and 8% of Latinx individuals. So this is key. So how are you supposed to be thinking about COVID-19 as a priority when there's nothing to eat in the home, and, or that you're having shortages of food, et cetera. Shortages in cleaning supplies were higher among Black and Latinx respondents. And then you can also see that there is differences in support from community organizations. So this right here is, again, another snapshot of the social determinants of health, or the social and structural factors that are going to, again, play into people's access and ability to have support services related to COVID-19 testing and care. And just like we were seeing across the board with the risk factors, with COVID itself and with HIV, there are disparities on the basis of race. So, next up. We have also had conducted in our survey questions that were included about interest in vaccination and COVID testing. And what we found is that there were significant differences that compared to gay and lesbian individuals, bisexual and pansexual individuals were more interested in vaccination, that non-binary individuals compared to cisgender males were more interested in, had higher odds of interest in vaccination. Same thing with transgender versus cisgender individuals, but that this is not true for people with HIV. So this needs to be more exploration into that point. And then in terms of looking at home testing, we see that bisexual and pansexual individuals more likely had higher odds than gay and lesbian individuals to test for COVID at home, but that this was not true. We see a significantly lower odds for intersex people's willingness to test. Transgender individuals were more interested in testing than cisgender individuals, but again, we see this pattern for HIV. So again, how, to think about what is the effect of these different attitudes towards vaccination and testing, and how people would like to receive testing pragmatically when thinking about rolling out public health programming. These are the types of studies that are really needed to think about how should we be moving forward, what types of community outreach should we be doing, who should we be talking to, how can we network across community researchers and epidemiologists with clinicians and public health service providers. Thinking about that from a structural level is going to be important as the pandemic continues and the vaccination rollouts are looking to increase. So then finally, the last couple of slides here come from very recent National Vital Statistics rapid release, again from the CDC, and this actually made a pretty big splash in the media last month, which was about decreases in life expectancy attributable to the COVID-19 pandemic. Overall, there was about a 1-year decrease in life expectancy prior to COVID versus post-COVID. So you can see the blue bar, darker blue bars here from 2019, the lighter blue bars are from 2020, and then you're seeing here on the y-axis, this is life expectancy, age in years, and then on the x-axis, we're looking at Hispanic populations, non-Hispanic white populations, and non-Hispanic Black populations. And you can see that although there was an overall a year decrease in life expectancy, this did not accrue equally across by different groups by race. And so you notice that the biggest gap here from 74.7 years to 72 years among non-Hispanic Black individuals. And then you can see this is another way to look at it, looking at change in life expectancy at birth by Hispanic origin and race and sex. And so what you can see here is that among non-Hispanic Black males, there was a 3-year decrease. Among Hispanic males, it was 2.4 years. Non-Hispanic Black women, Black females, it was 2.3 years. Among Hispanic females, it was like 1.1 years. Then we get to white populations, there's still a decrease, but it's only 0.8 years or 0.7 years. But this is still really striking because in 1 year's time, we've seen population level decreases in life expectancy due to this pandemic. And also we see again the effects of structural racism on how those differences in life expectancy fall. But in summary, COVID-19 is impacting marginalized communities in predictable ways, in ways that we've seen for HIV, in ways that we see for other chronic conditions, that we see at the intersections of multiple marginalization, so thinking about race, ethnicity, and thinking about sexual orientation and gender identity, or more accurately, thinking about racism, biphobia, transphobia, homophobia. At those intersections, we see an exacerbation of inequities related to COVID-19 risk factors as well as COVID-19 outcomes, and that LGBTQ and BIPOC people are less likely to experience the impacts of healthcare service disruption at a greater rate than white cisgender and or heterosexual peers. And so with that, I'm going to turn it back over to Monica to talk more about why these disparities are existing in the first place. I think you've heard a little bit about that just from our framing so far, but we really wanted to break it down. So take it away, Monica.
Thanks so much for that summary. So yeah, I think that's a good segue into, we just feel like it's important to just take a moment to review a few key terms and concepts to make sure that we're all kind of approaching these discussions with a shared language and understanding as to going into why these disparities exist in the first place. Oops, sorry. There we go. So starting off with structural discrimination, we truly believe in order to have a meaningful discussion about structural oppression and discrimination, it's really important to acknowledge that we all live and operate within an inherently racist heteropatriarchal system and that systematically disadvantages certain groups while privileging others. So it's just acknowledging that at baseline, no matter how nice we are as individual people, the systems in which we live will serve to uphold racism, homophobia, biphobia, and transphobia by default unless it's actively and intentionally interrupted. And these systems absolutely and unfortunately include our health system and the institution of medicine. So especially for those of us who work in healthcare, I believe we really have to hold ourselves and our institutions accountable to acknowledge this and then to commit to changing it. So we'll be reviewing intersectionality and stigma in a moment, but I'd like to start with race and racism as that's my main background. So let's be clear, race is a social construct with no biological basis. I imagine everyone here is familiar with this concept or has heard it before, but it's really worth unpacking. Both geneticists and sociologists agree that race has no genetic basis and that race is not equivalent to geographic ancestry or heredity, which are related to genetics. And so, you know, people may share some phenotypic characteristics like skin color and hair color, but that says nothing about how similar they are genetically. And if you've never seen this film, Race, The Power of an Illusion, it's, I highly recommend it. It's from 2003, a little bit after they finished the map of the human genome and discussed many of these issues. And so actually racial categories, as we know them, were made up long ago, as early as the 1700s, and have actually evolved out of Eurocentric historic ideas to justify colonization, genocide, and slavery. And, you know, because they are a social construct, arbitrary racial categories are dynamic and have changed over time and mean different things in different places. So in short, racism came first, and the man-made invention of race was created from it in order to justify and maintain ideas of biological superiority and a system of white supremacy. And by the way, I highly recommend Dorothy Roberts' book, Fatal Invention, and Ibram X. Kendi's book, Stamped from the Beginning, for really good summaries and primers of the history of how race was constructed and the implications it has today. And I know this seems like a tangent, so I just want to take one more second. but I want to say that I just think it's of utmost importance to spend time reflecting on this legacy of harm stemming from these flawed ideologies that are so deeply rooted in the very history of medicine, because this legacy continues today and has unfortunately really laid the groundwork for unjust and unethical practices in communities of color, such as the U.S. Public Health Tuskegee syphilis study, the uncompensated use of Henrietta Lacks's DNA for research, and forced experimentation and sterilization, which is a human rights atrocity that is happening still in ICE detention camps, unfortunately. And there are many other examples. And so there's like so many other talks on this that we could give, but I just want to quickly say that before handing it back over for talking about how this can be applied to gender and sexual orientation.
Yeah, thanks so much, Monica. That was a really, really great background. So we wanted to take a moment also to touch on how the characteristics which we commonly think of as connected to LGBTQ identity, specifically sex, sexual orientation, and gender identity, have also been socially constructed. I'm going to start with sex because I think those of us who work in clinical or research fields, we're trained to treat sex purely as a biological variable, but overwhelmingly that's a pretty significant simplification and also does a lot of work of erasing the social consequences of how we have constructed sex. So sex is a multidimensional idea. It's usually constructed around traits like our chromosomes, our genitals, our gonads, our hormones, our secondary sex characteristics, our breasts, our body hair, our voices, our fat distribution. There's a lot of different things that we think of as being encompassed by the idea of sex. And you might be thinking, wait, hang on, all of those things that she just listed are biological? And well, yes, that's true. And it's true that physical variation occurs in human bodies, generally in bimodal ways. Classification of that human variation into categories like male or female is a fundamentally social process with significant social consequences, particularly for women, for trans people, and for intersex people. And this is something that we think is really important to understand. This is also, of course, true of sexual orientation. It follows that if sex is socially constructed, so would sexual orientation be. Here again, we have an idea which is composed of a number of different components, including the labels that we use to identify ourselves or our identity, who we find ourselves attracted to, who we engage in sexual activity with, how we experience sexual or romantic desire or partnership. We have ideas of all of these things which are often condensed into very simplified labels like gay, straight, lesbian, bisexual. But life is messy, and so is sexuality. Things like our identity and behavior might not always align in the ways that we would stereotypically expect. And here, again, it's important to acknowledge that while differences in things like sexual attraction and behavior are naturally occurring, the way we label and define them has very real social consequences. And finally, I do want to touch on gender. I think we're a little more used to hearing the idea that gender is a social construct. I think, unfortunately, you hear that as an aphorism in opposition to sex being something biological, which is, I think I've kind of touched on, is a bit of an oversimplification. There are a lot of different aspects of gender that typically get reduced to just an identity. There's things like your expression or how you embody and present your gender relationally with other people. There are socially constructed gender roles that you might inhabit, which are influenced by things like our economic forces, our cultural values, interpersonal norms, behaviors, and roles, which are highly contextual and cultural. And then there's also things like the modality of your gender, which is a newer sort of idea which essentially describes where your gender sits in relation to the sex that you were assigned at birth. So we might consider cisgender and transgender to be two gender modalities such that women are women but can be considered either cisgender or transgender. And I think that this quote from Susan Stryker really drives home the point that we're trying to make here, which is that even though there is naturally occurring variation in human bodies and human societies, medical practitioners and institutions, and I would really add to this, epidemiologists, public health professionals, and researchers in general, have a lot of power to design, regulate, and define that difference and what it means for our societies. We have the power to, as she says, transform potentially neutral forms of human difference into unjust and oppressive social hierarchies. And that's what we're really getting at, and I think when we talk about something being socially constructed, there's often a misunderstanding associated with that idea that makes something less real or less important. But I think what Dr. Stryker's quote really kind of drives home is that the opposite is in fact true. injustices and disparities in health, like those we're talking about today, are born out of socially constructed differences and how those differences are regulated within the context of a society, culture, or state. The construction of difference and discrimination generally go hand in hand. I think that's the point that Monica made really beautifully, that it is racism that precedes race and not vice versa. And it is fear, it is homophobia and transphobia and biphobia that precedes the construction of categories that regulate difference. So I'll turn it back over to Monica to talk a bit more about how discrimination operates at different levels of society.
Sure, thank you so much. So beautifully said. I always think it's helpful to remind ourselves of the various levels of oppression which can be applied to racism, homophobia, transphobia. Just a quick reminder that there is internalized, interpersonal, cultural, structural, and institutional oppression. And I think interpersonal oppression is often what gets thought of the most because examples are pretty concrete and fairly easy to identify, like a hate crime being carried out by one person that directly harms another person, for instance. And that's where news goes to, and that's where a lot of training interventions tend to go to with implicit bias and personally mediated racism strategies. But sometimes I feel like what can be more difficult to see and understand is structural and institutional oppression because these are so woven into the normative fabric of our society. So I think we just wanted to show this just to remind of the different levels and just say that it's important to acknowledge that because we're talking a lot about structural oppression today, that many of the policies and systems in place in our culture, in our institutions, in our structures, they operate at default to uphold and perpetuate racism, homophobia, transphobia, sexism, and all the other isms. Thanks, and I'll turn it back over to Dr. Beach.
Thanks so much, Dr. Hahn. The next thing that we really wanted to highlight is something we started talking about a little bit earlier, which is the concept of intersectionality. And this is really important because intersectionality can really be seen to overlay all of the conversations we've been having about stigma, discrimination, it's occurring at different levels and along different axes, and to holistically capture it into this idea of what happens in terms of a whole person point of view when it comes to marginalization. And so intersectionality at its core and its history was founded as a Black feminist critical race theory based type of theoretical lens. What you can see here, I'm trying to tell the story a little bit in some pictures. On the far left, we see a picture of Sojourner Truth. And in terms of intersectionality scholars, we see that two additional photos on the right-hand side. We see Dr. Patricia Hill Collins and Kimberly Crenshaw. And often the storytelling of thinking about the origins of intersectionality that are attributed or go back to Sojourner Truth, like thinking about specifically centering the experiences of Black women throughout history and how both misogyny and racism together are collectively harming Black women. And also we see the Combahee River Collective statement there. That is a text that's really fundamental to Black feminist intersectional thought that also incorporates a lens on class and on sexual orientation as part of the different types of intersections of identities that get filtered through social power systems collectively and holistically that generates what oppression means in a lived experience way for people who are inhabiting intersections of different marginalized identities. And so you can see some links here. You can learn more. You can read the Combahee River Collective statement. The resources later on at the end of the talk that we provided also has the citations to writings by Dr. Kimberly Crenshaw. But I just wanted to emphasize again the historical roots of intersectionality is coming from Black feminism, and that I think should always be mentioned when applying what intersectionality means. And moving forward, I want to talk about intersectionality in public health, since that's the topic of this conversation. So what you're seeing now is a picture of Dr. Lisa Boleg, who has written a lot about how do we measure or assess or apply this intersectional lens to research. And also I think that this can be applied into medicine or clinical care. And some citations here to some really key papers by Dr. Boleg. So The first one you can see is the problem with the phrase women and minorities, intersectionality, important theoretical frame for public health. And so that the emphasis on the and there is really to think about how that for Black women or for Black gay men or Latinx, transgender individuals, et cetera, that the and is key, because it's not that you're just thinking about discrimination or stigma and marginalization on the basis of, say, sexism and racism, but if you don't look exactly at the intersections of both of those things, you can miss out on exactly what stigma or marginalization looks like for a particular group. And that's also really well illustrated in Kimberly Crenshaw's original writings. She is a legal scholar and talked about one of the first articles that really came out in Law Review was focused on how if under the law, protections on the basis of race and protections on the basis of sex ultimately did not wind up protecting Black women who inhabited the intersections of those spaces. And so there's a similar concept thinking about that structurally in public health. If you're focused on what are interventions for women, what are interventions for Black individuals, Latinx individuals, people of color, you're going to miss out on some really important information and ways of thinking about interventions at the intersection of multiple marginalized identities. And then you can also see this idea of the importance of the whole person and the whole experience through this, thinking about this lens of social power. So once you've blended the cake, you can't take the parts back to the main ingredients, Black, gay, and bisexual men's descriptions and experiences of intersectionality. So again, and then one of the things that Lisa, also Dr. Bolig, has written so thoughtfully about is how do we measure these things. Originally, the focus had been on qualitative research must be done to center the person in studies or to center the patient and patient care, et cetera. But then over time, there have been quantitative methods that have been developed that have been in which the developers have been striving to apply this intersectional lens, by ensuring that, for example, you can interpret findings at the person level and the population level in studies. But that's a little beyond the topic of this talk. And all of this, I think, collectively for this section transitions into this idea that stigma is a fundamental cause of health inequities. And so what you see here, this is a slide adapted from Mark Katzenbuehler's work, to do citation. You can see that stigma at multiple levels. So I think Dr. Hahn's slide really showed 5 different dimensions, but thinking of stigma holistically at multiple levels contributes to stress, anxiety, poor mental health outcomes that is then filtering down into health disparities and inequities, also through the social determinants of health. And so hopefully a key takeaway of these first 2 sections of the talk really have been, you can look at connecting these theoretical frames and stigma as a fundamental cause and structural and social determinants of health as having directly affected HIV, COVID, and other chronic health outcomes, especially at the intersections of multiple marginalized populations. And with that, we'll turn it over to Gregory. Oh, actually, I have one more slide, and that actually was the summary of what I just gave. Sorry about that. But this is a conceptual model. So for people who like to see pictures, this is another way of looking at the slide that was just presented by Mark Katzenbuehler's work. So here we see this is a paper that was published a few years back by David Lick and colleagues, and you can see that sociocultural stressors are connected to how people are perceiving themselves in relation to societal structures of, in terms of the structural, interpersonal, individual experiences of discrimination. You can see that this is linked to stress responses, both mental and physical in the body. And so we're connecting, again, stress to what happens in the body, and that affects, of course, our behaviors and then ultimately our overall health status. So just another way of summarizing the same concept, but in a different kind of visual look, in case that helps. All right. Now we will turn it over to Gregory.
Thank you for all of that. I'm going to build on that, talking a bit more about structural discrimination. I love this picture. A couple of years back, we had a Bias in Big Data event where Yeshi Milner, who's the founder of Data for Black Lives, came and spoke. And this is such a key slide to everything that we're doing. We know that race isn't a risk factor, racism isn't. Similarly, LGBTQ identity isn't a risk factor, homophobia, biphobia, transphobia is. And we've talked a lot about structural racism and the influences that that has. The same model can apply for structural homophobia, biphobia, transphobia. It's less explored, but it still has the same impact and it's still the same source of multiple health disparities. We like to think of everything as being a multi-level model. We have adapted the framework that Bronfenbrenner has used, the socio-ecological model. We use this to talk about our evaluation work, but this is also just a clearer picture of how all of the factors are interrelated. We know that a pandemic, COVID-19, HIV, whatever it is, doesn't impact somebody at one level. It has individual, network, community, and structural impacts. And it's key to understand all the different levels to actually understand where you might need to intervene, where the problems are, and what you need to do to address them. So with that, I'm going to turn it over to Dr. Hahn for a couple of slides before it comes back to me.
Thank you all for putting up with the many switchings back and forth. But yeah, we just wanted to take this moment to go through some examples of how structural discrimination operates and how it's driving disparities for various chronic diseases, including HIV and COVID-19. And again, my example is going to focus on structural racism because that's more where my background is. So I'm so grateful to have such esteemed co-presenters that will be talking more about examples in other areas. But I just want to take a moment to delve a little deeper into one example of a structurally racist policy that has had just lasting impacts for generations, which is redlining. And so just a few years ago, actually, researchers at UCSF examined health statistics in 8 California cities, including in the Bay Area where I live, that were highly impacted by redlining. And recall that redlining it was a tactic used by government officials to justify discriminatory mortgage lending policies in predominantly minority neighborhoods that were marked red on these maps. So the map on the left is an old redlining map. And this practice started in the Great Depression era. And as a result, many Black and other people of color were systematically denied the right of home ownership and then all the upward mobility that would be connected to that. And this study basically found that current residents today in historically redlined neighborhoods are more than twice as likely as their peers to visit emergency rooms for asthma exacerbations. And so you see here on the left is the redlining map, and on the right is the asthma map, where deeper shaded areas are corresponding to worse asthma outcomes. And after this study was done, more and more studies found that the old redlining map could be overlaid with many other health conditions, and the shading would match just like here, and with the historically redlined areas corresponding to worse health outcomes. And so this same phenomenon now has been published on and seen in preterm birth, cancer, depression, many other conditions. And so what it suggests is that old policies like redlining, even though it was outlawed as a practice on paper in 1968 by the Fair Housing Act, it has caused severe intergenerational harm rooted in residential segregation, which is a legacy that is still really deeply impacting our health outcomes today. So when it comes to health, place matters. And now I wanted to show one other look at this other deeply rooted institution that our country was founded on, slavery, and how that's impacted us for generations. And I know many of you have likely read the New York Times 1619 Project, looking deep into this history, and if you haven't yet, I highly recommend it. But this map on the left is 150 years old. It's using 1860 census data, and it shows counties in the southern United States which are shaded to reflect what percentage of their population was enslaved at the time. And this map is from 538. They recently did this really awesome interactive map project where, like the redlining maps, it overlaid this 1860 map with the distribution of many modern-day health conditions, including HIV and TB, which is the map on the right. And guess what they found? Sure enough, similar patterns are found. And this map on the right, and I'm sorry that it's a GIF actually that animates, and it shows that the shading is the same, but it's stuck on the part of the video where it doesn't show the shading very well. But I highly recommend going to the website to see it. But basically what they found is that same distribution of deaths from HIV and TB can be overlaid onto the 1860 map. So the reason I like to show this as an example is that often I get really frustrated when I hear people say things like, oh, but slavery, oh, but Jim Crow, oh, but redlining, Tuskegee, all of those things are in the past and they're now over. And that, we had the civil rights movement and now everything's fine, right? And I hear people say, well, we need to move on now and stop dwelling in the past because we should just embrace colorblindness and move on. And what's frustrating to me is when I hear that, several concepts of critical race theory especially come to mind for me, as that's the background from which I came into medicine. Concepts I'm always thinking about are race consciousness as opposed to colorblindness and challenging ahistoricism, meaning that we can't move forward and understand how structural racism and all the other structural oppressions are affecting health today if we can't acknowledge the history and also realize that that history was not so long ago and is absolutely continuing to affect what's happening today. Thanks, and I'll turn it back over. Actually, I have one more slide, sorry. It's no surprise then when we come from that lens that when we see data like this that consistently shows that Black and brown communities are overrepresented in COVID-19 cases, as well as higher poverty, unemployment, and incarceration rates, these patterns of inequity track together. And so all the structural inequities with roots in oppressive policies like redlining, mass incarceration, and employment discrimination. So now I'll turn it back over to Dr. Phillips for more discussion. Thanks.
Thank you. So I'm just going to be talking a little bit more about Chicago since that's where the rest of us are based. These are just a few maps that are highlighting all sorts of different risk factors. Many of you may have seen things like this making the rounds on Twitter or whatever, where people are just saying it's the same map. It's really the same people are impacted by the same things. You can see here the same people who are experiencing the different risk factors, who are dying from COVID-19, are also the people who are the racial ethnic minorities. And in Chicago, this also maps onto HIV. Here you can see the HIV incidence rates and COVID-19. They're happening in the same places. And we're also seeing that the places where the vaccines are going are not the places that are most impacted, and that remains problematic with the response. It's the same map, it's just the same disparities being amplified by focus on majority populations. And I think that is it for me. I'll turn it back over to Dr. Beach.
Thank you so much, Dr. Phillips. And I want to also say that as a cardiovascular health researcher and a diabetes researcher, that the maps for those conditions look very similar. You can see across the whole country, there's this idea of the stroke belt, for example, and it maps right on to that same mapping, that imagery that was seen with the 538 project. You can see it in Chicago, that these historical legacies are alive and well today. They're part of our contemporary health. And so I also wanted to think of, to recenter this in intersectionality through that lens, because you can also see often that there are exacerbations of these inequities when you're thinking about race at the intersection of sexual orientation and sex and gender and class. And I also wanted specifically to call out ability or disability, that you see that these intersections are also amplified along those axes. And we're not going through all of these things today, but just to say that this is important across the board, and that the holistic effect is also really important as to why we see the same patterns and trends across all these conditions by place, by power, over time. And one thing that I wanted to talk a little bit about next is to return back to that Williams Institute report, or not Williams Institute, to the Williams Institute as a whole, because they really do a great job of putting out resources that focus on social determinants of health and across the intersections of race, sex, gender, sexual orientation, and geography. But this particular report is focused on poverty in LGBT populations. And so, excuse me, what you're seeing here from this analysis, which was published in October of 2019, on the left-hand side, we're looking at poverty among cisgender gay men, followed by cisgender straight men, cisgender straight women, cisgender lesbian women, cisgender bisexual men, cisgender bisexual women, and transgender individuals. And so this is not at the intersections here in terms of also thinking about race, but rather sexual orientation and gender, or in the case here, the sample is gender minority individuals, transgender individuals. And what you can see is that I think there's a lot of talk about poverty impacting women and people of color, also people with disabilities. Like those things are all true, but it's also true that we see the poverty impacting sexual and gender minority populations, especially populations of women, and that this report goes into a lot of depth if you're interested in learning more about poverty and its impact on sexual and gender minority or LGBT populations. Next, I wanted to go back to the COVID report. So this is that initial report that we were talking about earlier in the session. And this is looking, the outcome here is people that were recently laid off work, and we're looking at LGBT status and race ethnicity. So the first two bars here are among LGBT white individuals reporting being laid off recently, and then LGBT people of color report being laid off recently under COVID. And you can see, you can compare that to non-LGBT white individuals, so about a doubling in terms of that gap here between those two bars. And then if we look at people of color who are not LGBT, again, we see that the intersections matter a lot, and that the impacts of unemployment due to COVID are being felt across both racial ethnic minority and sexual and gender minority populations. So with that, I will turn it back over to Dylan.
Okay, thank you so much. So we have spent a lot of time going over the historical, the contemporary systems and structures that have produced the inequities that we're seeing. We'd like to shift our focus a little bit now, and now we're going to talk about how we and all of you can get involved in pushing back on those patterns and get involved in making a difference. And we're going to try to draw some of these lessons from the HIV and AIDS activism of the 80s. So we'll start by just kind of highlighting ACT UP, the AIDS Coalition to Unleash Power. I think one of the most important lessons that ACT UP taught us from AIDS activism is that silence equals death. Failure to speak out against injustice allows that injustice to persist. And when we're talking about health injustice, that means people will die. It was never the beneficence of medicine as an institution. It was never the power or the action of the Reagan administration that helped get medications to folks with HIV as quickly as possible during the height of the AIDS crisis in the 80s. It was organizations like ACT UP who used protest, art, and demonstration to make sure that science was advancing and was advancing as equitably as possible. I also really want to mention, though, on this slide that it can be pretty easy to conceptualize this sort of work as a thing of the past, but ACT UP still exists as an organization and is still working to address the ongoing disparities in HIV, even as these have kind of faded a little bit out of popular focus from where they were in the 80s. And biomedical advancements like PrEP, PEP, better ARVs, despite all of that, as Gregory mentioned earlier, the HIV crisis in the US never ended for many people, and it's arguably worse for many people today than it was in the 80s. And I think that ACT UP's work is a contemporary lesson as much as it is a historical lesson, and that's something that I think is very important to clarify, is the work that ACT UP and groups like ACT UP do, you know, these grassroots community-based organizations do to combat injustice in HIV and COVID-19 is work that we as health professionals can, and I would argue must, be aligning ourselves with and be supporting. When it comes to what that looks like, I think that this photo offers a really interesting case study. This is a picture of an ACT UP protester holding a sign that reads, "Dr. Fauci, you're killing us." And I think that one of the reasons this is so interesting is because Dr. Fauci has become somewhat of a celebrity in recent years due to his role in responding to COVID-19, particularly in the early months of the emergence. And I mean, like, justifiably so. But he also played a really critical role in speeding the process of research into and availability of HIV antiretrovirals. But he didn't just wake up one day and decide to do that. AIDS activists exerted a lot of pressure on Dr. Fauci and pressed him to do everything that he could to get life-saving drugs to people as fast as possible. To his credit, he listened. And that was one of the major differences between what he and other members of the Reagan administration did. His willingness to listen to protesters, often protesters who might have been described as violent, saved people's lives. And I think that that is so important because in the past year, we've witnessed a real surge in protests and demonstrations against police violence, against white supremacy, and in defense of Black lives. That's all connected to the COVID-19 crisis that's ongoing. The moment for us right now to listen to the people who are being most impacted by HIV, by COVID-19, by structural oppression has already come. It's here. There's no moment to wait for. As I think Dr. Hahn put so beautifully early in the presentation, the reality of structural inequity means that no matter how polite we are part of systems that produce and reproduce inequity. If we want to make a difference, we have to be willing to commit ourselves to disrupting those systems, disrupting the distribution of time, money, and power which dominate and define the systems that we inhabit. I think this also really kind of emphasizes the fact that we can't rely on criminalization when we're talking about dealing with COVID-19. This is a very specific sort of example, but it's one that I think is really important. We've talked a little bit about prisons as a sort of environmental injustice already, specifically when it comes to COVID-19. The lesson here is that we can't rely on the same practices that sustain structural injustice to address it. And the data is already bearing that out. Black people are being disproportionately criminalized for COVID violations. Latinx people are being disproportionately criminalized for COVID violations. And LGBTQ and Black, Indigenous people of color are already overpoliced and overrepresented in the prison system. We simply can't count on oppressive structure to fight oppression. So with that, I think I'll pass it back over to Dr. Hahn, who will talk about a few other ways that we can make ourselves part of the solution.
Thank you so much. So many, such incredibly important points. And yeah, I think what lessons all these powerful resistance movements from the past are leading us to is the lesson that we cannot win the fight to end COVID-19 or HIV effectively without recognizing the social justice aspects of health. You know, structural racism didn't just suddenly become a problem overnight when George Floyd was murdered this summer, right? His death was and the uprising that followed was a culmination and response to decades of violence and harm. And, you know, this summer, many health providers were standing up and demonstrating like they did during the HIV era, because we feel that right now, when it comes to structural racism, homophobia, transphobia, silence is complicity, and we cannot be silent. So, you know, I think during this unique time in our history, people are really rising up and boldly saying, we don't want things to go back to normal. You know, normal was what got us into this mess in the first place. Normal was too many people without health care, housing, and civil rights protections. Normal was unending state-sanctioned violence by police and expansion of criminalization and the carceral state. Normal was predatory, racialized capitalist policies that led to further under-resourcing of certain communities over others. So we really put up with normal for way too long. So given that, you know, where should we be focusing then our efforts? And I think many of the lessons learned for curbing global pandemics are historical lessons from HIV era. And some of them are summarized here in this UNAIDS graphic. Sorry, it's a little hard to see. But, you know, just understanding the importance of community input and engagement, the importance of fighting stigma and discrimination, including avoiding criminal sanctions, supporting the most vulnerable, or in critical race theory terms, centering in the margins, and stressing the importance of international cooperation and coordination, because infections know no borders and they don't abide by them, and so neither should a response to a pandemic. But we really need to push our institutions and hold them accountable to do this with us, and really boldly say that we don't want just your performative hashtags, we don't want your purely symbolic, you know, solidarity statements. We want to see the actual work and see the actual policy change and reallocation of resources to reflect these priorities. Thanks. And then I'm passing it back over.
Yeah, we'll just hot potato with the slides a little bit. Thank you. So a couple other specific actions that we can think about taking right now that will make a big difference. First is that sexual and gender minority inclusive data capture will ensure that we aren't left in the dark. I think as we kind of saw earlier, there's not a lot of good data out there on sexual and gender minorities when it comes to COVID-19. And most of what we know has come from smaller studies and often very underfunded studies like the one that, that we talked about that we had run ourselves. As of today, or as of when I wrote these slides, only 3 states were currently collecting sexual orientation and gender identity data for COVID-19. Pennsylvania, California, Nevada, and Washington, D.C., which is not a state, but we still very much appreciate that that's happening there. But that kind of data collection is one of the most effective ways that we can monitor population-level disparities. We can't act if we don't have information. Information and knowledge are often power. That said, standardization and modernization of our SOGI data capture systems is incredibly important. I'm seeing a question come in about how this data is collected. Testing sites, contact tracing, something else, all of the above. Our hospital, our medical system, our existing surveillance systems that don't capture sexual orientation or gender identity, but yes, definitely includes testing sites, contact tracing, and direct patient care. The other, I think, concrete lesson that we can take away from this is decarceration, and this is an incredibly important one. This is an effort that I would encourage all of you to think about getting involved in. There's a growing body of evidence, some of which is cited and quoted on this slide, that shows that decarceration is an evidence-based matter of both justice and population health. The prison system is a major detriment to the health of our country, particularly in the context of a viral respiratory pandemic. It's also obviously a fundamentally racist institution, but it is also deeply, deeply problematic for our overall population health. In terms of both of these initiatives, I would really encourage everybody to see if there are initiatives relating to SOGI data capture in your state or initiatives related to decarceration in your state. I would strongly encourage you to find ways to get involved with those initiatives. Dr. Hahn, I think it's back to you now.
Thank you, and I know we're coming close to the close of this, and I want to make sure that we have time for questions, but we wanted to make sure that we touched on, because it's just such a current issue, the inequitable distribution of this highly anticipated COVID vaccine, and talk a little bit about medical mistrust. And I'll just briefly say that, you know, much of this inequitable distribution has been blamed on medical mistrust in BIPOC communities in particular, which we want to be clear does not account for the majority of vaccine inequity, and it really fails to acknowledge the many structural shortcomings that underlie the inequitable rollout, and that, you know, it has far more to do with access to power and resources than it has to do with mistrust. But also wanting to say that, you know, the term medical mistrust is very problematic in and of itself, and really puts the onus and blame on patients for not trusting the institution of medicine, when actually mistrust is a very valid and appropriate trauma response to an institution with such a deeply entrenched history of medical racism. You know, and our healthcare system, unfortunately for many, really represents a site of ongoing violence, a site that pathologizes minoritized communities and takes away their autonomy, and sites that produce narratives of blame, and all the other examples of historical mistreatment and human rights violations that we referenced earlier. And it's not just about what happened in the past, it's about what's continuing to happen today. So instead, really, you know, the onus should be on us as health providers to do the work to earn trustworthiness. We need to dismantle the deeply rooted systems of oppression in healthcare so that we can truly have it be a space that's truly patient-centered and community-centered healing. And I won't go on and on, but for more great information on this topic, I also highly recommend Dr. Oni Blackstock, who talks about medical mistrust a lot, and has been a really amazing resource, and I've learned a lot from. I wanted to take a minute to talk about this. This is a Hofrichter model. I just feel like, you know, where do we even begin to address these problematic legacies and even begin to undo this harm? And, you know, I feel like the answer is we really need to interrogate and disrupt oppressive structures. And I think this model outlines well how social structures like institutional racism, class oppression, and gender-based discrimination are related to power and wealth imbalances, through various policies, which in turn affect social determinants of health and then result in disparities. And, you know, COVID may be a novel virus, but these underlying structures and policies are not. That's why this talk is titled New Pandemic, Old Inequities. And so really we're grappling with the repercussions of decades of systematic disinvestment in certain communities and the layering of all these intersectional forms of oppression that's yielding absolutely devastating results. And then we're layering HIV and COVID on top of those structures. And this is how we got to where we are today. So just closing out, you know, where do we go from here? You know, I truly believe it is to lead with an intersectional anti-oppression framework, and that's exactly what is happening, and that's exactly what this discussion is. And working towards anti-racism is part of that, and that's the conscious decision to make frequent, consistent, equitable choices daily. And these choices require ongoing self-awareness and self-reflection as we move through life. And this can absolutely be applied to sexual orientation, gender, and other intersectional areas as well. And it's a process. It has no endpoint. It's lifetime learning, and it's hard, but critically important, necessary work. And so, you know, right now we're in the midst of a movement where people are coming together for change. There are calls for universal health care, universal workers' protections, calls for decarceration, calls to truly invest in communities that have suffered from historical underfunding and divestment, and calls to denounce systemic racism and structural oppression. So I'll just end by bringing this message back to HIV. You know, we have highly effective HIV treatment and medications. Movements like ACT UP helped us get to this frontier of medical innovation. I mean, now we have amazing monthly injectable ART. We never thought we would have that, right? And so that's not what's holding us back right now in keeping our communities safe and healthy. HIV stigma and systemic oppression are what's holding us back, especially for historically marginalized communities. And that's really the frontier that we have to tackle now. And so the fact that we're here today discussing HIV and COVID not in a vacuum, but with an intersectional anti-oppression lens is super encouraging and is absolutely the direction we need to keep going. That's the only way we're going to improve the health of all of our communities, whether it's HIV yesterday, COVID today, or something entirely new tomorrow. So thank you so much to all of you for listening, to my amazing co-presenters for being a part of this critically important work. Let's just keep supporting each other and growing together. Thank you. And I think we wanted to show some resources at the very end as well for further reading.
Yeah, I really want to echo what you just said too. It feels very powerful to be able to speak about this in a professional setting and be able to speak very openly about it. But I will also say, as much as we have loved being with you today, and as much as the four of us, I think, could talk about these topics forever, we are getting close to when we need to wrap it up. So before we go, we wanted to leave you with a few resources for further reading and learning, because as was just mentioned, this is lifetime work. This doesn't stop today. So I'll get us started with a few books which I consider to be essential reading. The first two are really focused on issues like decarceration and the prison abolition movement. Are Prisons Obsolete by Dr. Angela Davis, and Captive Genders, Trans Embodiment in the Prison Industrial Complex, which is written by various authors. If you are curious about the ways in which the prison system structurally and individually impacts LGBTQ and Black, Indigenous, and people of color, these are two great books and great places to start learning about it. If you are curious about how to get involved with organizing against injustice, this I think is a very critical point. Here are two recent books that came out from incredible organizers and leaders in trans and racial justice movements. We Do This Till We Free Us, Abolitionist Organizing and Transforming Justice by Mariam Kaba, and Mutual Aid, Building Solidarity During This Crisis and the Next by Dean Spade. I would really recommend that you look to these as guideposts for how to start organizing in your space and how to get involved with justice work that is so necessary now and always. I think I'll let everybody talk about their own recommendations. So here's number two.
Oh, sure. These are some of my recommendations. I mean, there's so many, and I really want to uplift the countless amazing scholars doing work in the area of structural racism in medicine and anti-racism. So these are just a few that I listed and that I had mentioned before during the talk. But there's one other on here that I wanted to just mention is Dr. Chandra Ford's work has been really about applying critical race theory to public health, and she also has a background in HIV, and I really appreciate her work as well.
So the next couple of resources here are focused on if you're interested in getting more training about LGBTQ health or LGBT communities or identities, or if you're interested in perhaps thinking about how to develop a quality improvement program that centers sexual and gender minority health and an intersectional lens. There are a couple of resources here. So the one I'm going to start with is at the bottom, which is the National LGBT Health Education Center from the Fenway Institute, which is located in Boston. There's a link there to the Learning Resources page, which has lots and lots and lots of articles, of webinars, of YouTube videos, of training that can be accessed on your own time. And there are also new resources being added all the time. So you can watch the webinars live as they come out and then go back and see the recording. And then the other, this is just a paper that I had put out with some colleagues last year. It's published in a journal that's part of the Joint Commission. So it's the Joint Commission itself also has quality standards when thinking about LGBT patient care from a systematic view. So just recommend checking them out.
And I'll just quickly go over this list. So this is from a paper we published as a team a few months ago, and we have a lot of recommendations for what people can do to actually meet the needs of LGBTQ individuals during the COVID-19 pandemic. I'm not going to read all of these, but I think each of these we've touched on during this talk, and I think if you are interested in any of these, the link is there. We're happy to talk more about them, but we really think the only way we can end the disparities within HIV, COVID, any future pandemics is really to address all these structural issues, structural racism, structural homophobia, structural transphobia, and that's the only way we're going to be able to have any impact. And I think that's it. This is our last slide with our contact information.
Yes, thank you, Dr. Phillips. So thank you all. Thank you to our presenters for that excellent presentation. And also thank you for everyone for your engagement in the chat box. At this time, we do want to open up for questions. We do have a few minutes left to ask questions. As a reminder, you can unmute your line by pressing #6, or you can continue to use the chat box to add your question, and our presenters will address them. So for our presenters, I just want to go to two questions that I know I saw earlier. One from Judy Collins, who brought up provider stigma is problematic as well. How do you address that?
I think that's a really important question because, and there is a bit of a focus on that, and the resource I pointed out that's on in the Journal of the Joint Commission work for patient quality and care. And it really talks about how providers and everyday interactions and how providers are trained or not trained affects the overall quality of care in a health system that patients receive. And so I think it's important to understand how can providers, what education are providers getting? What does that education look like? How frequently is it occurring? I think if you're part of a healthcare system, to ask for training on topics of how to provide care from a non-judgmental point of view, recognizing that stigma isn't just always focused on patient populations. It's not always just racism, transphobia, biphobia, homophobia, misogyny. It's also HIV stigma, sexual stigma. One thing that I've done some work on in my own research pursuits is diabetes stigma. So, and then of course we've talked about COVID, the stigma against COVID. And so there are ways that you can measure provider stigma on these different dimensions to assess yourself. But I think also just requesting trainings and asking that they be offered annually or quarterly, on an ongoing basis is important. And then so is designing monitoring systems at the health systems level to identify where stigma might be affecting patient care and quality of care. So but it's definitely, it has to be a multi-pronged approach. But also this training has had some tips about stigma, I think, in ways to educate yourselves. Like if you're a provider, coming here is a great step. Reading some of the resources, engaging that some is a great step. And realizing that there's also the Behavioral Diabetes Institute, if you're interested in diabetes stigma. There are papers being published now, like how to use non-judgmental language in chronic disease management. Also if you think about HIV, thinking about undetectable as a phrase versus suppression or control, when talking about patient care, and not blaming patients for being sick. I know that sounds really simple, but it's really a thing. Like that's the starting point here, was that blame and shame really are the bedrock of stigma, and stigma is the opposite of health. So thinking about how can you use motivational interviewing to talk to patients about about improvements in their care, where they're at with their care, thinking of social determinants as affecting everyone's health care. Those can be some important things too. But yeah, I think I'll stop there.
Great, thank you, Dr. Beach. An additional question I had saw earlier from Alora McGavin had asked, how is this data collected? Is it by testing sites, contact tracing, or something else? So Laura, if you're on, if you can elaborate a little bit more. I don't know if the speakers are available, familiar with what data they may be referring to, but if you can elaborate on that.
I believe that was about the SOGI data collection that was asked about when I was presenting on that. Alora, please let me know if I'm incorrect in saying that. But yeah, my response is the same. All of the above are great ways for that data to be collected. Contact tracing is very important for sure. Testing sites is very important within hospitals and health systems, very important. Our broader public health surveillance efforts, like Lauren talked a little bit earlier about the behavioral risk factor surveillance system, the youth risk behavior survey, these sort of national health surveillance projects are really important places to update and or modernize our SOGI data collection. And then, you can even think bigger. We can even think about the census. We can think about all of the ways that we're able to pull in, that we're able to access data related to health, because it's certainly more than just those. But yeah, all of the above is the short answer. So thank you for asking that.
Great, thank you so much, Dylan. And there was a question, and thank you, Dr. Beach, for providing a resource. There was a question on, is there a resource you can suggest that outlines non-stigmatizing language as it relates to HIV? And Dr. Beach provided an excellent PDF resource in the chat box. Okay, so we have time for one additional question. Are there any other questions for today's presenters? How do you think the sped up pace of vaccine approval will affect HIV vaccine approval?
I think that's a really interesting question, because a lot of the approvals for the COVID vaccines have come under their emergency authorizations. And HIV, as you may know, has already changed the landscape of FDA regulations due to the pressures from HIV and AIDS activists like ACT UP, et cetera. Before the pressure received from those groups, there didn't used to be expedited review processes for medications, and so like after phase 2 trials have been done, you could get authorization and approval that pending the results of phase 3 trials to get HIV, to have HIV medications come out in the time that they were really needed. And I'm not sure if we would see necessarily that HIV vaccines would be approved by emergency use authorizations or not, or how the regulatory system may change. But I would say that no matter what, that community voices and protests and activism would be the thing that spurs that change.
Great, thank you so much, Dr. Beach. And someone, Helene, did mention in the chat box the difference in viral structure affects vaccine development. So with that said, once again, I just want to thank our excellent speakers for this talk. Thank you so much for joining us. And a very special thank you to the MidAtlantic and Pacific AETCs for their role in coordinating and identifying today's speakers. We want to let everyone know that the slides and the recording will be available on the AETC and CRC website within about a week or so. If you have any questions, feel free to give me a call, send me an email. And thank you so much for your time. We hope that you join us for session 7 in the last session of this HIV COVID-19 series. Thank you.